for this Pudukkottai Budan webinar. And formally, I request ISA Pudukkottai Secretary Dr. M. Periyasamy to offer welcome address.
Thank
Over
you,
to
sir.
you,
Thank
Dr.
you.
Periyasamy.
Good evening, one and all. On behalf of ISA Pudukkottai, I wish you all advanced Ether Day on behalf of ISA Pudukkottai. So we ISA Pudukkottai is continuously conducting this online webinar ISA program. This is the 30th week. So this 30th week ISA program, I welcome you all once again for this online ISA webinar program. On behalf of ISA Pudukkottai, I welcome our academic chairman Dr. A.L. Meenachandram sir, our president Dr. Suresh Kumar sir, treasurer Dr. David, and member of ISA Pudukkottai delegates. I welcome you all once again in ISA webinar program. So this program is continuously conducting for the past 5-6 months as Pudukkottai Budan. So already we started this program on 23rd of March 2022, and we conducted so many programs in so many headings. These are leads we already conducted. Last week we talked about anesthesia management of hypothyroidism, anesthetic management of thyrotoxicosis with the atrial fibrillation and thyroid storm. This week we are going to talk about 3 different topics. For this ISA webinar program, I welcome Dr. Nalini Kotikar, Professor and Head, JSS Medical College, Mysore, Consultant, and Kamachi Hospital, Mysore as a Chairperson. I welcome you, Madam.
Thank you, sir.
And next, I welcome Dr. Sarika, Associate Professor, JSS Medical College, Mysore. Madam is going to talk about understanding cleft lip and palate. I welcome you, Madam. And next speaker, Dr. Anil Kumar, Associate Professor, JSS Medical College, Mysore. Sir is going to talk about anesthetic management of cleft lip and palatal surgeries. I welcome you, Madam, on behalf of ISA Pudukkottai.
Thank you, sir.
And one more speaker, Dr. Kusti, Junior Resident, JSS Medical College, Mysore. Madam is going to talk about Pre-Operative Laryngoscopy. So once again, I welcome you all for this ISA online webinar program on behalf of ISA Pudukkottai. As you all know, this program is accredited by Tamil Nadu Medical Council, and they are giving credit hours for delegates. For that, 100 to be paid to the account number of 3856859629 for our account of bank account. The details are given here. For that, we need your ID and your mail ID, your mobile number, and your attendance certificates. I mean your screenshot of attendance. Those particulars have to send to the ISA Pudukkottai@yahoo.com. As I already told about Ether Day, we are going to celebrate Ether Day on this October 16th, coming October 16th. This small poem about the Ether Day. W.D.G. Martin, the man behind the ether magic, who turned the world towards his logic, learned the physics of ether and became anesthesia father. Ether and soul of everyone seeking it, and wondered the world by whoever breathes it. Operation theaters were occupied by this angel, alleviated the pain and allowed the procedure for our gain. In those days, everyone might have inhaled it. Everyone might have experienced it. Everyone might have yearned by it. So era has been changed after ether evaporation. Entire world gained after ether inhalation. October 16th, the ether day. Let's be unite and salute WDG Martin. With this, I thank you all. I thank everyone for this opportunity. Thank you, sir. Over to Academic Chairman, Dr. A.L. Meedasundram, sir.
Thanks, Dr. Periyasamy. I think our President ISA Pudukkottai, Dr. Suresh Kumar, is having some technical hitch. So I want to inform all of you that this is the best topic possible, and I have received so many messages stating that this cleft lip and palate is a wonderful subject. So before I go into the detail, I request Dr. Suresh Kumar, our President ISA Pudukkottai, to offer the presidential address. Sir, you are not audible. Not audible, sir. Sir, shall we come at the end? Now, to present the topics like perioperative laryngospasm and understanding cleft lip and palate and anesthetic management, we wanted to have the extraordinarily top faculty. Then we thought of Smile Train, because Smile Train is a program which concentrates on cleft lip and palate. When there is a question of Smile Train, automatically Dr. Nalini Madam came into our mind, and we have catch hold of her faculty to present this cleft lip and palate. See, these people, mainly the youngster, Dr. Pushti, she is graduated MBBS from Gujarat, and she is pursuing post-graduation in JSS Mysore. She is a Bharatanatyam dancer. By her look, she may not look like a Bharatanatyam dancer, but she is a good Bharatanatyam dancer. She is interested in anesthesiology. That is the reason why she has taken it out of interest. And she is having the topmost privilege of sharing this webinar session with the two associate professors under the chairmanship of a retired head of the department. So I congratulate Dr. Pushti for entering the Pudukkottai Budan platform, and I thank you very much, Dr. Pushti. You can stop sharing. Then comes Dr. Sarika M. Shetty. So Dr. Sarika Madam, even though she is an associate professor, by work-wise, she behaves like a postgraduate. Whatever work is interested to her, immediately she carried out. And she is a member of this All India Difficult Airway Association. In fact, all the three are members of All India Difficult Airway Association. And Madam is part of it. And Madam is part of the Smile Train campaign. So they have anesthetized many cases in northeast part of India, because we think that northeast region is underprivileged, and the Smile Train team under the leadership of Dr. Nalini, they travel place to place and they offer these benefits to the downtrodden people, and Dr. Sarika Madam is one among that. Comes to Dr. Anil Kumar, he is also an associate professor, and he is a gold medalist during his MD in Rajiv Gandhi University. Then he is editor for Karnataka Anesthesia Journal and so many other journals. And if I mention the certificate courses he has attended, it will be a big topic. But mainly, he is an instructor for ACLS, BCLS, ATLS, and he got his certificate course in ultrasound guided regional anesthesia, this echo, this critical care, so many. Whatever the subject, even that percutaneous tracheostomy, routinely we are doing it as a procedure, and he is certified in that. And he is certified by California that he has covered a basic foundation course in that critical care setup. With all these degrees and graduations, he is a part of Smile Train campaign. And this team is doing wonderfully well. And Dr. Ramkumar sir also joined from Manipal. It is a privilege for us, for Pudukkottai Budan. And when these three top people are talking, who can chair the session other than Dr. Nalini? Because we had only Smile Train. By name, we know that. And whenever we see that jargon, we will smile and we will go. We will not be a part of it. But these people are living for it. So we have to acknowledge that we smile and go. But these people live and they're still living only for that Smile Train campaign. That is a big deal. And Madam has served, Nalini Madam has served in JSS Medical College, Mysuru for more than 30 years. But if you see their face, she will be aged only 30 years. That is a big part of Nalini Madam. The smile still continues. More than that, the magnetic voice she possesses, which I listened to it some 20 years back, still she is having the same voice because she is living for anesthesia. She is living for students. And she used to say, the Smile Train campaign is inherited in her DNA. So, madam, it is a DNA or RNA or whatever antigen, antibody, you are the topmost in that Smile Train campaign. And specifically, I want to tell only one thing. Madam is now working in a private firm, Kamakshi Hospital, but she takes a break and tours. We used to go for religious pilgrimage after retirement, but Madam is seeing God in the poor man's smile. That is the reason why she is part of Smile Train campaign and she is leading that. The best part I want to say, Madam has authored a book, Anesthesia Residency Manual, which I want to even prescribe for the postgraduates. The Anesthesia Residency Manual, even in my Facebook, my WhatsApp group, everything I have dropped a message. That is a very good book, Anesthesia Residency Manual, which can be accessed digitally also, which you can purchase it online. So all postgraduates, please make use of this experienced teacher in the form of a book, Anesthesia Residency Manual. It is not only for residents, even for practitioners and professors who are not knowledgeable like me. That is, so these people can also follow this book. She has comprehensively, she has detailed everything. Madam is working for this and still she is having the affection to the postgraduates. That is the best part of a teacher. And whatever topic you give to madam, she will teach it very nicely because I am seeing her for so many years, maintaining the same enthusiasm. She is also smiling. She is making others to smile. So with this little bit of introduction about madam, I hand over the session to Dr. Nalini madam. Please give us a visual and auditory treat so that we can smile after listening to you. Thank you, madam.
So thank you so much. First and foremost, a big thank you from
Over to
all
Dr.
of
Nalini
us,
madam.
our entire team. Thanks to Dr. Suresh and thanks to Dr. Periaswamy and of course Meenakshi Sundaram and the whole team for having us here today. There's a slight correction, Dr. Meenakshi. It's a big correction rather. It's not Smile Train, it's Mission Smile. And I was introduced to Mission Smile through Ramkumar sir himself. And he is the big man of Mission Smile. So I'm just one of the small tributaries who goes if he tells me to go to a certain place and manage the team kind of. So it's just a very small part of my routine. And I'm so proud to be associated with Mission Smile. And yes, Smile Train was also our fort in JSS Hospital for many years. And yes, it's been a wonderful journey throughout. And we are so happy today to come together. And Ramkumar sir, I'm so happy you joined us. So with that, I think we shall start our sessions today without wasting time. And I request Pushti to take over.
Thank you, ma'am. So, good evening, everyone. I'll be presenting on perioperative laryngospasm. So, coming straight to the topic, laryngospasm is defined as glottic closure due to reflex constriction of laryngeal muscles, the incidence of which in older children is twice that of adults, and in younger children, it is thrice that of adults. So it is mainly classified in two types. A complete laryngospasm, it is characterized by paradoxical chest movements, but silent chest with no back movement and no ventilation possible. Whereas a partial laryngospasm, it is characterized by paradoxical chest movement with presence of stridor with a mismatch between the patient's respiratory effort and the very small amount of back movement. Pathophysiologically, the innervation of supraglottic region, it is by superior laryngeal nerve, the internal branch, while below the cords, it is supplied by recurrent laryngeal nerve. So the afferent, it is from internal branch of superior laryngeal nerve, which converges in the brainstem at nucleus tractus solitarius. And the efferent is from recurrent laryngeal nerve, whose motor neurons relay in the nucleus ambiguous. The risk factors can broadly be divided into two types. One is the lack of inhibition of the glottic reflexes because of inadequate central nervous system depression. Another one is by the increased stimuli by secretions or blood irritating the vocal cords, artificial airway, laryngoscope, or suction catheter. We have next classified these risk factors into patient-related factors, surgery-related factors, and anesthesia-related factors. So the patient-related factors are high-risk airway anatomy and pulmonary history, such as recent history of upper respiratory tract infection, asthma, whooping cough, congenital airway anomalies, premature birth, electrolyte disturbances such as hypomagnesemia, hypocalcemia, surgery-related risk factors such as nasal, oral, or pharyngeal surgeries like cleft surgeries, adenotonsillectomy, bronchoscopy, UGI-scopy, anal or cervical or urethral dilatation due to Breuer-Lockhart reflex, anesthesia-related risk factors, out of which the depth of anesthesia is the most important one, vocal cord irritation, which may be due to secretions, mucus, blood, catheter, throat pack, or Gauspies, choice of inhalational agent, wherein desflurane contributes maximum to the laryngospasm, whereas sevoflurane is comparatively protective, and inexperienced anesthesiologist. This closure of larynx can occur at three different anatomical levels. One is the aryepiglottic fold, which exhibits sphincteric closure to oppose the epiglottis. These aryepiglottic fold, they are located at the entrance of the larynx and extend from the lateral borders of the epiglottis to the arytenoid cartilages. The vestibular folds or the false vocal cords, which compress and may completely block the supraglottic airway, and the true vocal cords, which close when the lateral clitoarytenoid, thyroarytenoid, and interarytenoid muscles contract, all of which are innervated by the recurrent laryngeal nerve. Next is how to recognize these. So any patient of any age group who is making a rigorous effort to breathe spontaneously but is not achieving effective air exchange, laryngospasm is to be suspected. Varying degrees of airway obstruction with paradoxical chest movements, intercostal recession, and tracheal tuck can be seen, followed by desaturation, which is seen as fall in the SpO2 and absent capnograph. There is a characteristic stridor or crowning noise, which may be heard in partial laryngospasm, with the presence of very minimal back movement. This is the sound that is characteristic of partial laryngospasm. Whereas in complete laryngospasm, there is absolutely silent chest with no presence of back movements. The reflex laryngeal closure, in terms of the larynx functioning, it is described as a shutter and ball valve mechanism, wherein the adduction of the two vocal cords will act as the shutter, whereas the ball valve is created by the closure of the false vocal cord due to approximation of the soft tissues of the laryngeal inlet above, extending from the hyoid bone to the notch of the thyroid cartilage. Next, we'll go on to the prevention. So any patient who comes with an ongoing infection of the upper respiratory tract, it is advisable to postpone the surgery for 2 to 3 weeks till the URTI is subsided and the airway is less reactive. During induction phase, it is advisable that an experienced pediatric anesthesiologist is present. Avoid manipulation of the airway, especially at insufficient depth of anesthesia. Choose an appropriate induction agent, may it be an inhalational agent or an IV agent, and muscle relaxant. During emergence, it should be taken care of that the blood and the secretions from oropharynx as well as trachea are adequately suctioned when the patient is still deep under anesthesia. Discontinuation of the inhaled agent or the intravenous agent. Checking for the residual paralysis. We should limit the stimulus until the patient opens eyes spontaneously, and extubation of the trachea only of a fully awake patient. Pharmacological prevention. It can be done by IV lignocaine 1 to 2 mg per kg 2 minutes before extubation, or topicalization of the vocal cords with 4% lignocaine spray. Magnesium sulfate at a dose of 15 mg per kg IV before extubation can also be used to decrease the airway reflexes and cough, and a no-touch technique, which is essentially awake extubation, which consists of pharyngeal suctioning and lateral positioning while the patient is still anesthetized, followed by avoidance of any kind of stimuli until a spontaneous eye opening is present and extubation takes place. Management of laryngospasm. So first maneuver is our continuous positive pressure. In partial laryngospasm, there may be an improvement with gentle positive pressure, in contrast with complete laryngospasm, which is silent and there is no movement of air between the closed larynx and the lungs. And any attempt at a positive pressure ventilation may serve only to aggravate the problem. Attempts to provide intermittent positive pressure ventilation with a face mask may distend the stomach, causing splinting of the diaphragm and making subsequent resolution of hypoxia even more difficult. Next is Larson's maneuver, which is essentially a firm upward pressure, which is described at a Larson point or a laryngospasm notch, which is bound anteriorly by the condyle of mandible, posteriorly by the mastoid process, and superiorly by the base of skull. During this maneuver, a continuous delivery of oxygen should be continued without any positive pressure. If adequate spontaneous air exchange is not resulted with all of these maneuvers, then next step is to deepen the plane of anesthesia without any delay, so that it lowers the risk of hypoxemia as well as negative pressure pulmonary edema. This deepening of the plane can be done by just increasing the sevoflurane or inhaled anesthetic agent, or use of IV agent, that is propofol, at a dose of 0.5 to 0.8 mg per kg. If it is not sufficient with this alone, then we can add on a muscle relaxant such as succinylcholine at a dose of 0.1 to 0.3 mg per kg. For infants and young children without IV access, intramuscular succinylcholine at a dose of 3 to 4 mg per kg can be given, or an intralingual succinylcholine at a dose of 2 mg per kg can be given. At these doses, at these approaches, intramuscular acts at around 45 seconds to 1 minute to break the spasm, and intralingually, it takes about 75 seconds to break the spasm. As the larynx now relaxes and the airway opens, any secretions can be cleared and mask ventilation now becomes possible. Complications associated with laryngospasm: hypoxia and hypoxemia, which is seen as central and peripheral cyanosis. Bradycardia, as succinylcholine is also known to cause bradycardia, it is preferable to give it together with atropine. Hypercarbia and negative pressure pulmonary edema. Negative pressure pulmonary edema mainly results from a very high negative pressure, which is achieved by the patient to overcome the upper airway obstruction, as seen in this case of laryngospasm. A normal pulmonary fluid homeostasis is the net fluid transfer across the pulmonary capillary, which mainly depends on: one, the difference between the hydrostatic and colloid osmotic pressure, and second, the permeability of the capillary membrane. Now, when a patient deeply inspires against closed glottis, especially young healthy subjects, they can generate a very high negative pressure, up to 140 to 160 mmHg, which is transmitted to the intrapleural space. This increases the venous return to the right heart, thereby increasing the pulmonary venous pressure. This increased pulmonary venous pressure now causes movement of fluid from the pulmonary capillaries to the interstitium and the alveolar space. As well as the negative intrathoracic pressure, it increases the afterload by increasing the transmural left ventricular pressure. Therefore, it also increases the ventricular wall tension. This increased afterload then decreases the LV ejection fraction, which finally leads to further hypoxemia, decreased myocardial contractility, and increased pulmonary arterial resistance. Concluding my topic, it is very essential to diagnose laryngospasm first, which is marked by inspiratory stridor, paradoxical chest movements, decrease in the SpO2, use of accessory muscles, no capnogram. After identification, it is utmost important that triggering stimulus should be removed, further which we should do a chin lift head and jaw thrust maneuver, call for help, at the same time assess for bag movement. If minimal bag movements are present, that means it is a partial spasm, wherein we can go ahead with a gentle positive pressure and Larson's maneuver. But if the bag movements are absent, we should directly go ahead and deepen the plane of anesthesia, either with sevoflurane or propofol. Then assess again. If the bag movement is still not present, then we should go ahead with muscle relaxation with succinylcholine 0.1 mg per kg and watch for bradycardia and supplement with atropine if needed. Again, if the SpO2 is not further increasing and the patient is worsening, we should not delay in taking a call on front of neck access and go ahead with cricothyroidotomy or tracheostomy. Whereas if there is an increase in SpO2, that calls for resolution of the spasm and we should wait for recovery. In the recovery ward also, close observation should be made to see for secondary complications such as negative pressure pulmonary edema. Thank you very much.
Thank you, Pushti. That was well covered. And the reason Pushti got this topic was she's handled a case herself last week in the Jharkhand Mission Smile program, and probably we'll tell her to share her experience once the topics are over, because Dr. Meenakshi Sundaram told me that we'll have all the discussion at the end. So could we have Sarika moving on to the next topic, please?
Good evening. I'm Dr. Sarika, Associate Professor in the Department of Anesthesiology, JSS Medical College. At the outset, I would like to thank Pudukkottai ISA branch and Nalini Madam for giving me this opportunity to speak on my favorite topic, that is anesthesia for cleft lip and palate surgeries. So coming to my topic, that is understanding cleft lip and palate. It is very important from the anesthesia perspective because there are so many concepts here. It is associated with so many syndromes, congenital anomalies. Another important thing is we have a shared airway concept and the difficulties with airway management. All these characters of cleft lip cleft deformity put the patient at greater risk, and it is very challenging for the anesthesiologists. Now, contents of my presentation would be normal anatomy of the lip and palate, embryological development of lip and palate, the types of orofacial cleft, the incidence, etiology, what causes are responsible for the development of this cleft deformity, the pre-surgical management, pre-anesthetic assessment, which is a very important consideration. We have to look into so many different aspects, and the pre-anesthetic considerations. Now, coming to the anatomy of the upper lip, it consists of the mucosal membrane, the vermilion, and the cutaneous surface. It extends from the nasolabial folds to the inferior margin of the nose, as we can see here. The philtral ridges on either side of the philtrum increases the surface area, allowing the lips to expand during swallowing. A very important anesthetic implication of the upper lip is the upper lip bite test. As we all know, it is classified into 3 different classes, and this is useful in the probable assessment of difficult airway. Coming to the anatomy of the palate, hard palate is made up of two structures, that is the palatine process of the maxilla and the horizontal plates of the palatine bone. As we can see here, this is the horizontal part of the palatine bone and the palatine process of the maxilla. Here, the incisive foramen, which is this part, represents an important part because here it divides, the incisive foramen divides the palate into anterior, that is the primary palate, and the posterior, which is the secondary palate. So the secondary palate is posterior to the incisive foramen, whereas the primary palate is anterior to the incisive foramen. The soft palate is attached to the posterior ridge of the hard palate, and the uvula is centrally placed in the soft palate. Nerve supply has very important anesthetic considerations because it is important in the post-operative analgesic care of following the cleft lip and palate surgery. The upper lip is supplied by the intraorbital nerve, which is a branch of the maxillary nerve. And as you can see, it emerges from the intraorbital foramen, where local anesthetic can be easily deposited following cleft lip surgery. That is for only for cleft lip surgery. This is very important. And coming to the palate, it is supplied by the greater and lesser palatine nerves, which is a branch of the maxillary nerve, and also the nasopalatine nerve. The suprazygomatic approach to block the maxillary nerve is very useful in pediatric patients following cleft palate surgeries. Why does this cleft deformity occur? The embryological, for that it is important to know the embryological, normal embryological development. Lip and palate development occurs between 6 to 12 weeks of gestation. Upper lip and primary palate are formed from the fusion of frontonasal prominences with the maxillary prominence. As you can see here, this is the frontonasal prominence, which later forms the lateral nasal prominence and the medial nasal prominence. The medial nasal prominence joins with the maxillary prominence to form the primary the upper lip. Any defect in the fusion of this frontonasal prominence with the maxillary prominence results in the cleft lip. As you can see here, the medial nasal prominence and the maxillary prominence join together to form the upper lip. So any defect in this fusion results in cleft lip. Now coming to the palate, fusion of lateral palatal process, or what we call as the horizontal shells, it arises from the deeper portions of the maxillary prominence. Initially, these lie vertically like this. These lie vertically because there is a tongue which is placed upwards, but along with the mandibular development, the tongue moves inferiorly, allowing the partial shells to assume a horizontal position. As you can see here, the two horizontal shells move in the midline and fuse together to form the hard palate. So any defect in this fusion will give rise to cleft palate deformity. So you can see here how important is the incisive foramen. The anterior part, as it has already been explained, it is the primary palate, and this fusion forms the secondary palate. So this is the embryological development. This is another structure, similar figure to explain the embryological development. It is almost same. So this is the primary palate and this is the secondary palate. You can see here it is joining in the midline, and any defect in this fusion will give rise to the cleft palate deformity. Now, what happens in Peary-Robin sequence? When there is micrognathia is responsible for all the deformities found in airway of the Peary-Robin sequence. That is, because of micrognathia, there is no place for the tongue to move downwards, and hence, with the tongue being stuck upward between the horizontal shells, the cleft palate deformity remains, and then there is, because of that, there is glossoptosis, cleft palate, and as I've already mentioned, micrognathia is the responsible factor for most of these defects in Peary-Robin sequence. Now, what are the types of cleft lip? Cleft lip basically by definition refers to a fissure in the upper lip, as it is seen here. The types are, it could be incomplete, wherein only the lip is involved, or complete, wherein it extends into the nasal cavity, as it is seen here. And again, the laterality will define whether it is unilateral or bilateral when both the nostrils are or both the sides are involved. What are the types of cleft palate? Again, as the name implies, it is a gap in the palate. It could be incomplete, wherein we have already seen what is a secondary palate and a primary palate. So any defect in the fusion of the secondary palate will lead to incomplete cleft palate, as it is seen here. It is extending only up to the secondary palate. It is not including the primary palate. This is the, if this structure explains the palate from as seen from the oral cavity. So this is the primary palate and this is the secondary palate. So here you can see that the cleft deformity extends only up to the secondary palate. So it is incomplete, whereas the complete deformity extends from the alveolar ridge to the uvula. So again, this can be unilateral or bilateral depending on the laterality. What is the anesthetic importance, the main anesthetic importance, which will be explained by Dr. Anil later. So the insertion, during insertion of the laryngoscopic blade, the flange will slide through the cleft and causes difficulty in laryngoscopy. So as is seen here, a folded gauze or the naso-alveolar mold can be kept to make laryngoscopy easier. What is the incidence? In 2003, WHO conducted a survey and they have found that the incidence was around 1 in 700 live births. And it is surprising that the statistics hold good even after 20 years. Cleft lip with or without cleft palate is more common in males and cleft palate is common in females. Cleft lip is unilateral in 80% and left-sided in 30% of the cases. 85% of infants with bilateral cleft lip have cleft palate. And in India, the statistics is again same. It is 1 in 700 to 800 births, which there is 28,000 to 35,000 cleft deformity cases per year. Now, here are the few postulated etiological causes for the development of cleft deformity. Isolated anomalies without any syndromes occur in around 61%. One postulated theory is genetic mutation. Familial occurrence is around 3 to 5%. And another interesting fact is that if a father had cleft deformity, the chances of the first male child to have this deformity is very high. Maternal alcohol and smoking is a contributing factor in recent years. Drugs like anticonvulsants, phenytoin, benzodiazepines, salicylates, methotrexate, and cortisone are all associated with the development of cleft deformity. Infection like rubella virus is also associated, and increase in parental age is considered to be an associated risk factor. Now, folic acid at the dose of 400 micrograms per day is considered to be beneficial in prevention of cleft deformity. Again, it is just a postulated theory. In the prenatal ultrasound examination, the upper lip assessment can be done in 16 to 20 weeks of pregnancy. If it is diagnosed, then it is essential that other syndromic features are also looked into. So that is the main importance of diagnosing cleft lip deformity. As you can see here, the cleft lip is easily visible at 16 to 20 weeks of age. It is visible here too. So palatal deformity, as is very evident, as is very obvious, it is very difficult to diagnose. But if it is if there is micrognathia or polyhydramnios, cleft palate deformity should be suspected. Now, another important aspect for anesthesiologists with the diagnosis of cleft deformity by ultrasound is that if at all there is a risk of postnatal respiratory distress is suspected, then the anesthesiologist will be called for emergency management of the airway. So this is another important consideration for anesthesiologists. Now, coming to the pre-surgical management, there is something called as the naso-alveolar mold, which can be placed as shown in this picture. And what are the advantages? This is actually made by as per the child's requirement. Now, what are the advantages? The advantages are it improves feeding, obviously, because there is no nasal regurgitation. It guides the growth and development of the palatal segments. It approximates to some extent the palatal segments, so there is easier surgical approximation and it reduces the surgical time. It improves till the surgery is done. It improves the aesthetics and provides psychological comfort both to the child and to the parents. As soon as the diagnosis of cleft deformity is made, there should be a formation of the cleft team, which involves the operating surgeon, the concerned anesthesiologist, the pediatrician who is responsible for optimizing most of the medical conditions, the geneticist who will look into the genetic mutations, nursing faculty who is very crucial in the management of post-operative care of cleft deformity patient, ENT and audiologist who will look into the speech and hearing deformity, the speech therapist who will correct the speech deformity, and the dentist who will obviously look into the dental malformations. Now, why at all is it required to get the surgery done? What are the problems associated with cleft deformity? There is a dental problem, which also includes malocclusion. There may not be any eruptions at all. The skeletal problem, there could be different types of skeletal deformities if the palate correction is not done. Airway obstruction, which can be an obvious feature of obstructive sleep apnea. Because of the veilopharyngeal insufficiency, there could be feeding abnormality, feeding problems, regurgitation and microaspiration will continue to happen. Speech and hearing deformity is very, very crucial. The most important thing, of course, in a patient with cleft lip deformity is cosmetic appearance and psychological. Sometimes when these kids are born, there is social isolation and child abandonment, which are quite common. And the important goals of surgery include improvement in the veilopharyngeal function, which will take care of the feeding, regurgitation, the airway obstruction problems, improvement in speech, and cosmetic improvement. Now, what is the ideal time for cleft lip and palate surgeries? Cleft lip is operated between 2 to 3 months of age to improve feeding and for better coordination of oral structure. Some centers advocate the surgery being done within 1 week to improve feeding. Cleft palate is operated between 9 to 12 months of age to optimize speech development, and that is the time when speech development occurs, and to reduce nasal regurgitation. So earlier repair would cause mid-phase hypoplasia in future. Kilner's rule of 10 is for cleft lip surgeries, wherein the child should be 10 weeks of age, 10 pounds in weight, hemoglobin of 10 grams per deciliter, and less than 10,000 leukocytes to confirm that there is no active infection. The pre-anesthetic assessment goals include correction of the medical conditions, which include investigations to detect congenital heart disease. That is one of the common associated with cleft deformity. Optimization of any other medical conditions like upper respiratory tract infection. We have to plan the procedure and we have to prepare whatever we have planned for. Pre-operative advice and prescription of specific medications prior to anesthesia. Psychological aspect of the child and the family has to be taken care of, and informed consent has to be obtained. Now, coming to the specific pre-operative assessment history. In history, we have to ask about prematurity, wherein the risk of apnea is very high in children with post-conceptual age of less than 60 weeks. History of recent upper respiratory tract infection. I'll be telling you how we have to deal with patients with respiratory tract infection. Activity is very important because any lethargy in the patient could be an indicator of underlying pathology. History of apnea while feeding and sleeping. History of cyanosis, dyspnea, and squatting could be another indicator of congenital heart disease. History of snoring and combined with apnea could be an indicator of obstructive sleep apnea. Regurgitation of food. Seizures is important because the medications associated with seizures has an important consideration in anesthetic management. Allergic history, latex allergy could be a common thing. So familial history of any allergies also should be inquired. And history of previous anesthesia. If the child is subjected to any anesthesia earlier, anesthesia-related complications, which could include post-operative complications, has to be inquired. There are different syndromes associated with cleft deformity. The most common one being Treacher-Collins, velocardiofacial syndrome, Goldenar's syndrome, Down syndrome, fetal alcohol syndrome, Peary-Robin sequence, Klippel-Feil, and Stickler syndrome. These are the common findings in these syndromes associated with cleft deformity. Now, these are the pictures, few pictures to show that these are the different syndromes. Here is the Treacher-Collins syndrome, Peary-Robin sequence. As I've already mentioned earlier, there is micrognathia, glossoptosis, and cleft deformity and glossoptosis. This is a fetal alcohol syndrome and velocardiofacial syndrome. Now, in a child with pre-operative, when we go for pre-operative assessment, if the parent gives history of URTI, then what do we do? If it is a mild cold, that is only runny nose, dry cough, and watery congestion, then we have to treat with salbutamol, and we can proceed with anesthesia. That is, it is better to go with the use of laryngeal mask airway. If it is moderate, we have to weigh the risk-benefit ratio, and the risk factors include child less than 1 year. There is passive smoking, pulmonary comorbidity, and other airway, ENT, and eye surgeries, and endotracheal intubation. The benefits, this is generally given for all other surgeries. So expertise of the anesthetic team should be consulted, and the proper decision should be taken. If it is severe cold, that is with a runny nose, moist cough, wheezing, purulent congestion, fever, and malaise, it is recommended that surgery has to be postponed for more than 2 weeks. Now, what are the reasons why surgery should be postponed in patients with the upper respiratory tract infection? There is signs of respiratory infection when there is rhonchi, wheeze, purulent nasal discharge, fever, and lab investigation reveals leukocytosis. What is the significance of prematurity? Like already mentioned, post-conceptual age less than 60 weeks carries the risk of apnea of prematurity. So intense monitoring is required, especially in the post-operative period. Bronchial hyperactivity will be there. Intraventricular hemorrhage with hydrocephalus can be there. Prolonged intubation history has to be elicited, and glucose monitoring, if less than 3 months, has to be done. General examination we should look for any evidence of syndromic features, signs of malnourishment. As there is feeding problem, signs of malnourishment should be considered, that is the weight and height. And other general examination includes cyanosis, pallor, edema, temperature, signs of respiratory distress, that is any dyspnea, the respiratory rate have to be taken into consideration. Craniofacial skeleton has to be observed, and the muscle tone, joint hypermobility will suggest of other associated syndromes. If the child is sleeping, observe for snoring, and murmurs can be auscultated. Airway examination, again with the syndrome, like Peary-Robin sequence, it will be very obvious that it is a difficult airway. Always look for signs of difficult mask ventilation, laryngoscopy, intubation, supraglottic airway insertion, and also front of neck access. So these are the areas in which airway assessment has to be done. So any micrognathia, retrognathia, or glossoptosis is a definite indicator of difficult airway. Dentition has to be checked. Intraoral pathology has to be looked into when there is enlarged tonsils, and neck extension in Down syndrome has to be examined. It is obvious that in a child, it is difficult to have this airway assessment being done, but whatever it is possible, we have to get an idea of how the airway will be during induction. Now, difficult laryngoscopy, these are the 2 studies done. Difficult laryngoscopy was found in large or bilateral clefts with micrognathia and age less than 6 months. And Mallampati scoring, it is not given how they've done this Mallampati scoring, but it is considered to be an independent predictor for obstructive sleep apnea and difficult intubation in children. Lab investigation, it is recommended that only relevant lab investigations have to be done. Hemoglobin is very important, especially in cleft palate, where we expect a certain amount of blood loss. Total count should be done to check for any active infection. Nutritional status is very important because Chattopadhyaya has found that 74% of patients were anemic and 91% had low serum levels in a group of patients with cleft deformity in Uttarakhand. Renal function test if renal disease is suspected, bleeding time, clotting time, chest x-ray if pulmonary pathology is suspected, and echo in cleft lip surgeries where it is done at a very early stage. It is better done because to rule out any congenital heart disease, because it may not be evident without any symptoms. Pre-anesthetic preparation, as we have already discussed all this while, difficult airway cart has to be ready, proper intravascular access has to be there, and grouping and cross-matching for cleft palate surgeries has to be done based on the maximum allowable blood loss. Now, what is the advice we give to these patients or to the family? Fasting guidelines for pediatrics as per the latest guidelines. It is 1 hour for clear liquids, 4 hours for breast milk, 6 hours for infant formula, cow's milk or non-milk solid food, and 8 hours for fatty fried food. Now, to make the long story short, this is the gist of what we have gone through all this while. Anesthetic considerations, important anesthetic considerations are that 275 to 300 different syndromes are associated with cleft deformity. Recurrent chest infection has to be taken care of. Cardiac abnormalities in these patients include tetralogy of Palate, atrial septal defect, and ventricular septal defect. Problems of prematurity is already discussed. Gastroesophageal reflux and micropulmonary aspiration has to be considered, which is a main cause for recurrent chest infection. Obstructive sleep apnea is an important risk factor for anesthesia. Hypotonia has to be considered because anesthetic drugs have to be managed, have to be given. Airway difficulties, intravascular access, malnourishment, and blood loss during surgery. So that is the gist of the pre-anesthetic assessment and how much we should understand about cleft deformity before we go ahead with anesthesia management in particular. So to conclude my talk, this is a smile does matter at the end of it. So anesthesia pre-anesthetic assessment is an important component of cleft deformity correction. Thank you.
Thank you, Sarika. That was very comprehensive indeed, and I hope all the youngsters have taken note of all the points that we need to keep in mind when we are examining a child with cleft lip or palate posted for surgery. Ramkumar sir, am I audible now? Am I audible? Could somebody tell me?
Very soft still, Dr. Nalini.
Very soft.
Yeah, I don't know why.
Okay, I will.
I'm not sure about the others.
Can come back, but before that, I think I can ask Dr. Anil to start his series, his slides, and continue the session.
Yeah, good evening all. Thank you, madam. Again, I bring greetings from my institute, JSS Academy of Higher Education and Research, Mysore. Slides not moving. So I have no disclosures, no conflict of interest, and informed consent is taken by all my patients post some of the data I am presenting today. So coming to the topic, anesthetic management of cleft lip and palatal surgery. Thanks to Dr. Sarika for putting an introduction already. And I'll be stressing a very important points that is taken from our comprehensive pre-anesthetic evaluation. The cleft lip and palate, these are the most common craniofacial deformities and most common congenital anomalies that is observed in our clinical practice. Surgery is required mainly for aesthetic as well as the functional reasons. Functional reasons being, it improves the feeding, the swallowing, to improve the speech, to better quality speech, to improve hearing, and also it has got a long psychological implication. So to prevent this, these are some of the reasons why the surgery is essential in this group of patients. It's also very important to understand that cleft palate and lip surgeries are elective surgeries, and these are never an emergency urgent surgery. As already discussed, multidisciplinary team approach, including an otolaryngologist, plastic surgeon, oral surgeon, dentist, the occupational and speech therapist, and including psychologist. What is an optimal time when these people should undergo surgery? Dr. Sarika already discussed about this. Just to put an extensive highlight on this, generally it is 6 weeks to 6 months per cleft lip, whether 6 months to 12 months in a cleft palate surgery. The reason being, this allows time for detection of other associated anomalies, if any, and also allows for a better anatomical and physiological maturation of the baby. Now in Western world, the recent guideline has changed for early neonatal surgeries. The reasons being, it reduces the incidence of middle ear infections, and which is also very less in an early neonatal period. The speech development becomes more normal and more better. More effective orthodontic treatment can be instituted early. It reduces scarring as a consequence of better wound healing, and it has got a great psychological advantage of early bonding and breastfeeding in a neonate. The palatal surgery, a clean balance has to be maintained between a poor facial growth with an early repair and poor speech development when the repair is done in a later stage of more than 1 year of age group. This is very important for a postgraduate to understand why these timings are selected, depending on this background physiological reasons. As an anesthesiologist, my consideration, very important consideration, whenever we happen to anesthetize a oropharyngeal surgery, in particular the cleft lip or palate, my consideration is airway, the bleeding, comorbid conditions, associated comorbid conditions and syndromes, and the hypothermia. So I better to remember it as the ABCs of cleft lip and palate. In airway, it is seen that more than 90% of the airway the morbidity and mortality related to this particular group of surgery of lip and palate is only because of the problems of airway, and airway. It may be because of an airway difficulty, or a post-operative airway obstructions, or an interoperative airway compromise in terms of the named complications. As a difficulty, we may encounter the difficulty in mask ventilation, or a supraglottic difficulty in insertion of supraglottic airway device. A most commonest problem with airway is the laryngoscopy and intubation. Extubation is always neglected. It should always be considered the extubation given by equal amount of respect while extubating these cases, because there is a high chances of airway compromise immediately in post-extubation period. And also we are dealing with a shared airway here. The obstruction part, I will talk in my next future slides. The most common airway complications observed in these group of patients include bronchospasm, laryngospasm, as well dealt by Dr. Pushti, the frequent desaturation during intraoperative and post-operative period, post-operative breath holding, and post-intubation group. Very important to note that in these infants, greater than 10% of blood loss should be a trigger for blood transfusion. Associated comorbid, which anesthesiologists are interested, are about the associated airway anomalies, associated cardiac, most commonly the ventricular septal defect and atrial septal defect. These patients are malnourished because of a difficulty in feeding, and also they suffer a physiological anemia because this is a time period of 3 months to 6 months when HbF, the fetal hemoglobin, will get converted into an adult hemoglobin. The other important comorbid conditions which we are interested are, as already dealt, upper respiratory infection, and gastroesophageal reflux, which leads to microaspiration in these group of patients. Then the hypothermia. The issue is very important when the surgery becomes prolonged, associated with a blood loss and an ambient OT temperature. The child is at a high risk of developing hypothermia and associated complications. What are my challenges? The anesthesiologists frequently face the challenge in these groups because the children will not cooperate for airway examination, and there are no objective criteria to anticipate or to tell that this particular group of patients are at an anticipated difficult airway, particularly in these young children or infant. So we more dependent on the gross anatomical variation like the presence of microgranthia, retrogranthia, or age less than 6 months to 1 year, large or bilateral defect. Any of these should make us think that this particular airway is going to become difficult. And shared airway, the problem of shared airway is the shared airway is always bad. Remember it as bad, that the tube can get contaminated with the blood, debris, and a limited access. When the child is draped completely for a surgery, we have got a limited access to the airway, and a frequent tube dislodgement can be an issue when we share the airway with the surgeon. Then difficult venous access and limited access to the lines, airway, and chest when the child is completely draped. So shared decision making is a key to the success. So shared decision should be between the surgeon, between the anesthesiologist, and all the team members of the operating room. Come to the pre-anesthetic evaluation. Already in detail, Dr. Sarika has helped us and she has made my job easier. But a quick checklist before a patient is wheeled onto the OT table, I need to check for the nil by mouth status, weight of the patient. I will check for the consent. I will see the hydration status of this child, history of any previous very important history and surgery, features of any congenital heart disease, airway anomaly, and in particular about upper respiratory infection. It becomes very important for an anesthesiologist to differentiate between chronic rhinorrhea and active ongoing upper respiratory infection. You already learned it. Because the obstructive sleep apnea patient or a patient with a chronic airway obstruction, they're more prone for an airway obstruction, as well as they're extremely sensitive for our anesthetic sedatives agents. So we need to be very careful while planning a pre-medication for these group of individuals. The investigations, bare minimum, hemoglobin, complete blood count, and you know the rationale behind these investigations, blood grouping, bleeding time, clotting time, and urine routine. Extensive comprehensive investigations are not routinely required for this group of patients, except you identify them as having other anomalies or congenital heart disease. This rule of 10 is already discussed. Then coming to the pre-medication. The pre-medication, once again, mainly depends on the institutional protocol where they practice these cleft lip and palate anesthesia. Routinely, pre-medication is not required. If required, or depending on the institution, the intranasal dexmedetomidine or the midazolam can be used, mainly to prevent the separation anxiety. And glycopyrrolate is used to reduce the secretions. Even that is not routinely practiced in our own personal experience also. We're not using glycopyrrolate routinely in these cleft cases. The preemptive analgesia, the term now it is changed as pre-operative analgesia. So this can be administered in form of paracetamol 15 to 20 milligram per kg, which reduces the intraoperative and post-operative requirement of analgesics. Monitoring must include electrocardiogram, non-invasive blood pressure monitoring, arterial oxygen saturation, temperature, and capnogram. Induction again depends on the institution protocol. It can be either with the inhalational induction using sevoflurane with 100% oxygen. In a resource poor setting, we can use halothane with 100% oxygen, particularly when IV line is not present. But contrary to the previous thoughts, where the inhalational induction was thought to be the safest way of inducing a difficult airway, it has been observed in this special group of lip and palate, about 70% of these patients suffer laryngospasm. So you as a practicing anesthesiologist, you must be aware of these particular complications. If IV line is present in our institute, routinely the IV line will be present before the child enters an operating theater. It can be induced with propofol and fentanyl, or if sedation is required, injection ketamine 0.5 milligram per kg body weight along with glycopyrrolate can be given at the preoperative holding area before just wheeling the patient onto the operating theater. After sufficient depth, confirm mask ventilation before giving muzzle relaxant. This is very important, though our IDA guidelines and most of the airway guidelines suggest that muzzle relaxant must be given without taking a mask ventilation because it aids in a better ventilation or it improves the bag mask ventilation. Because most of these cleft lip and palate surgeries, not only they are done with a sophisticated institutions, it is also done in a CAM basis where we are new to the setup, and also we may not be all required instrumentation may not be available like advanced gadgets like video laryngoscope, bronchoscopes, or a well-trained assistant may not be available. So it is always prudent to confirm for the bag mask ventilation before giving muzzle relaxants. The routine muzzle relaxant use is succinylcholine 1 milligram per kg body weight or atracurium 0.5 milligram per kg body weight bolus dose. This is a very interesting story. This is a patient who was posted for cleft palate. You can see in the second picture. So immediately after induction, the patient developed severe laryngospasm. You can see that as a retracted chest, where then with the help of the Thrive, the high flow nasal oxygenation, we got an extra time to intubate or to handle this airway. Come to the intubation, the tube of choice is the RAE South Pole tube, if available. The problem with this particular tube is it has got a preformed curve. When the preformed curve is there, so if it is not suited properly for a particular child, it can lead to a kink in the other side, and also the suctioning becomes difficult. But this is a choice when it is available. The other tubes that can be used are the flexometallic tube. In our institute, we routinely use the conventional endotracheal tube without any problems. The tube should be fixed in the midline to the lower lip. Throat pack has to be inserted and it has to be boldly told and it has to be written and announced, because we should also remember to remove it at the conclusion of the surgery. As an airway anesthesiologist, a very important point to be remembered is when the surgeon puts the retractor, the Dingman's retractor, watch for the displacement of the tube or the endobronchial movement of the tube, inadvertent extubation and compression leading to rise in airway pressures. So these are the very important observation we need to do as soon as the surgeon puts his retractor. Come to the airway techniques. Maintain spontaneous ventilation and ensure ease with bag mask ventilation before muzzle relaxant, as already discussed. Laryngoscopy should not be attempted until the patient is in deeper planes of anesthesia. Direct laryngoscopy with birth maneuver, that is backward, upward, rightward pressure, and the use of gum elastic glue. These are very low cost, simple and effective techniques in a difficult airway scenario. But remember, the position of the tube should be checked whenever the patient is moved. When there is a large palatal cleft, see in this picture, we can see there is a large bilateral cleft in the first picture, and there is a cleft palate, the huge cleft palate in the second picture. The solution for this is the most commonly the flange of the laryngoscope can get stuck in the palatal defect, making the Corman Lahens, the higher grades of Corman Lahens grade. Putting a piece of gauze, packing this palatal defect completely can improve the laryngoscopic view. Or instead of using a curved blade, use a straight blade and use a lateral or the molar approach compared to the conventional approach. Along with using external laryngeal manipulation makes the intubation easy. Still, it is not happening. Use a laryngeal mask, which provides an excellent means to maintain an airway and ventilate the lungs. it also can be used as a guide to fiber optic bronchoscope the larynx, where we can railroad endotracheal tube over that. The advanced airway technique that are used are video laryngoscopes, flexible bronchoscopes, and elective tracheostomy. So we should not end up in any situation where we need to do an emergency tracheostomy because the landmarks are not well palpated, and we are also not acquainted, we're not used to a routine front of neck access in these particular age groups. Coming to the maintenance of anesthesia, the volatile anesthetic, it can be done either with a volatile anesthetic with or without opioids, along with regional anesthesia, or total intravenous anesthesia with propofol or ramifentanil in the West. We use propofol and fentanyl. It can be maintained either with a spontaneous respiration or controlled ventilation. The perioperative analgesia must involve the multimodal analgesia, which may include either the opioids, the paracetamol in the dose of 15 to 20 milligrams per kg per oral before as a pre-medication, or through intravenous route during intraoperative period. NSAIDs, routinely we use diclofenac sodium per rectal, or in other institutions, the ibugesic 5 milligram per kg board can be used per orally before 1 hour before the surgery, or ketorolac 0.5 milligram per kg body weight in IM intramuscularly can be used either during intraoperative period or post-operative period. The ketamine in the dose of 0.1 to 0.2 milligram per kg body weight gives an excellent sedation as well as analgesia, which can be extended in the post-operative period. Dexmedetomidine has got an added advantage of being anxiolytic, anti-sialagogue, opioid-sparing analgesic effect. It reduces an emergence and also does not cause respiratory depression. So dexmedetomidine, we use a loading dose of 0.5 to 1 microgram per kg body weight only. Bolus dose, we don't use the infusion dose. The regional blocks, as already discussed, provides an excellent analgesia both intraoperative as well as post-operative period for cleft lip surgery using an infraorbital nerve block. The suprazygomatous maxillary nerve block is used for cleft palate surgery, but most of the cases it is not sufficient as alone. So it has to be supplemented with an opioids or NSAID group of drugs. Dexamethasone, it has got threefold usage. One, it also provides as an excellent post-operative nausea vomiting strategy. Because of its anti-inflammatory analgesic property, reduces the requirement of other analgesic drugs. Because of its membrane stabilizing action, it reduces the airway edema, which is very important in these group of patients because it increases the resistance by almost 16 times. Coming to the fluids, it depends on how long the perioperative fasting period. And because they're having low reserve of glucose, glucose-containing solutions like half DNS can be used for maintenance of during a surgical procedure, and balanced crystallized solution like the RL can be used for replacement of fluids. Extubation, the rule is no blind suctioning of the oral cavity is allowed in any oropharyngeal surgery. Any suctioning has to be done under direct visualization. Look for hemostasis and suction only if required, and use a midline approach rather than passing the suction catheter laterally. Remove throat pack, announce it and document it in your case sheet. Avoid repeated instrumentation. Restraining the arms or the hands of the child is extremely important because it may rub over the cleft lip sutures, or the child may put their finger into the mouth, distorting the palatal sutures. The rule is awake extubation whenever possible, and coughing and straining has to be avoided by taking care of extubation press or response, which increases the chances of bleeding and airway trauma as well as post-operative airway occlusion. Coming to the post-operative care, the ultimate disposal or the destination of this child depends upon the airway difficulties and as well as the intraoperative events. Routinely, these dependency unit, the basic minimum monitor requires the monitoring of heart rate. Particularly, we should watch for bradycardia, which can be an ominous sign of hypoxia when it is unmonitored, and for saturation. The supplement oxygenation should be provided not through the nasal prongs, which can irritate, which can disrupt the sutures. It has to be provided through a face mask, or there is a modification in this particular picture where we have, if you carefully see, through the oxygen pipe, we have connected a plastic glass. So it acts as an oxygen insufflation over the patient's face. The baby has to be nursed in lateral or semi-prone position to aid the secretions drainage. I am worried in the post-operative care about 4 very important elements, that is the post-operative airway obstruction, the post-operative pain, bleeding, and the early institution of the oral liquids. The post-operative airway obstruction can be tackled to some extent by administration of dexamethasone 0.1 to 0.2 milligram per kg body weight intraoperatively, by applying the tongue stitch or the insertion of the nasal trumpets. Why these patients are more prone for airway obstruction? Because of pre-existing chronic airway obstruction or obstructive sleep apnea. The overall airway reduces with the surgery, the size of the airway reduces, the tongue becomes flappy, it falls back because of the effect of residual anesthetic effect, sedative effect, or the muscle relaxant. The prolonged retraction compression can lead to the tongue swelling, the unsuctioned or a retained blood clot, alarmingly the throat pack, and the laryngospasm. These are some of the reasons why the airway obstruction can lead to a problematic scenario at the post-operative period. This can be handled by simple reposition of the child in either in a lateral and prone position in more than 50% of the patients. Just positioning the baby can take care. If not, then jaw thrust with application of a continuous positive airway pressure. Be careful while inserting nasopharyngeal airway. With concern with the surgeon and the help of them, gently insertion of nasopharyngeal airway can tackle this program, particularly when palatal surgery is done. Oropharyngeal airway, whenever possible, try avoiding it. Though it is not contraindicated, be careful while using oropharyngeal airway for maintenance of an air, to maintain the patency of an airway. Last resort is to go for re-intubation, which will be absolutely difficult because of an existing airway edema, the alteration in the overall the structure of an airway, and the bleeding conditions. So to take home, a high index of suspicion for conditions associated with cleft lip and palate should be identified. A difficult view of laryngoscopy is more frequent finding in these group of children. Vigilance and open communication with the surgical team is necessary. Patient should be extubated when fully awake with close observations for the signs of airway obstruction. Children with cleft should be managed by a multidisciplinary team of experts. Thank you.
Anil, thank you. That was a very comprehensive compilation by you about the anesthetic management of a child coming for cleft lip and palate. And there are a few questions for you in the chat box, but before that, I would like to, since my voice was not heard earlier, I would like to welcome Ramkumar sir, and because he is the trustee and a very, very, very active person behind Mission Smile. And I would like to welcome our plastic surgeon, Dr. Satish, who was integral in bringing Smile Train to JSS many, many years ago. And definitely Naglakshmi madam, who was a professor and head of the department when Smile Train came to our hospital. So we'll involve all of them in our discussion. But before that, I think, Anil, you would have to take a few questions that are in the chat box. The first question was, what do you do if you need to use a fiber optic in this child for a difficult airway? How would you go about
it? The thing is, first in these cleft lip and palate, even as with our experience and with the literature, the fiber optic requirement is very less. Most of the time, they will have a problem with the using a laryngoscopic blade. If at all, if I want to use, since these are children who are uncooperative, they will not be still on the table. So we need to go with, in routinely, in our institute, we go with a high flow nasal oxygen so that it gives us extra time, and also with IV sedation. When we give IV sedation with high flow, patient is also still, and it provides me extra time, maybe about 15 to 20 minutes without getting desaturated, which also maintains the saturation and gives an ample time for me to secure an airway.
That's right. And if I could add a point, what I have come across is that you could use the fiber optic and introduce a catheter through the suction port into the vocal cords and then thread the endotracheal tube through that. That's one. And second thing is using a pediatric bronchoscope. You could pre-thread the tube onto that and then pass it after a good amount of inhalational anesthetic has been given and the child is quite deep. So those are the two methods that I have found quite useful during difficult intubations in these children. And as you said, difficult laryngoscopy is there and difficult mask ventilation is there, but usually intubation is not difficult in these patients in experienced hands. So I guess the use of fiber optic, as you said, is very rare and probably not really required in these patients, unless we have syndromic children with severe retronathia or tracheocolons or those kind of babies. Yes, Anil.
The question was awake fiber optic in infants, I think somebody has asked, but there is no scope for awake because children will never cooperate. It has to be with some sedation or inhalation insufflation with some age.
Yes.
So patient has to be kept immobile or sedated with some sort of sedation, either IV or inhalation.
Yes, that's right. And somebody's asked a question about tube fixation. Tube fixation is, I think, of paramount importance. And in one lovely practice that I have seen in Mission Smile is we use a transparent fixator. You know, it's a transparent tape kind of a thing, tegaderm, wherein it is supposed by chance, like as you said, you know, these are preformed tubes. There every chance that, you know, the tube will be oversized for our Indian population. So in that case, you could put a small gauze underneath that and then put a transparent, tegaderm on that. And but under no conditions I have seen that will the tube even move 0.5 millimeter. It does not happen. And then after that, you've got to put maybe a couple of pads under the circuit, you know, at the chest, just above the chest, and fix it once again, once the child has been lifted into position. Right, Anil? So yes, I hope that answers.
The greatest advantage is because it is water resistant. Even when if the betadine or any other secretions touches those tegaderm, it will not get loosened. Unlike our conventional tapes, the bandage what we use, with the soakage, it will loosen, and by the time we see at the extubation, almost 1 centimeter or 0.5 centimeter tube is out majority of the time. So that problem is negated with the use of these the tegaderm
usage, right? Because one thing that we have to keep in mind is occlusion, compression, and extubation can happen at any time of the procedure. So it is not just during this time, but you know, during the positioning of the patient, but it can happen just about any time. Another question that somebody has put is about regional block. Anil, are you there? Okay.
Yes, madam.
Okay. Okay. The question that has been asked is about regional block. Probably, I think you covered it. Probably the method to do the block for a cleft lip and a cleft palate was what you wanted. I guess that is there in all the textbooks. But Anil, would you like to quickly touch upon that?
For cleft palate, routinely the infraorbital nerve block is done. Cleft lip. So
yes,
lip, only for cleft lip it is useful. And there are two ways of doing it: intraoral approach and the extraoral approach. In extraoral approach, which we commonly use, though it does not correlate with the proximate line from angle of the mouth, palpable. We should measure the distance from the angle of the mouth till the palpable fissure. That is the eye, that is below the eye, from the lower part of the eyelid. You measure that length and suppose if it is 16 millimeter, 8 millimeter, half of that distance you draw a line from nasal ala so that where it intersects, it approximately corresponds to the entry of that infraorbital fossa. So perpendicular to the skin, you take a 26 gauge needle and the infiltration of about 0.5 to 1 ml of 0.25% bupivacaine is sufficient to cause the infraorbital nerve block. It works even with the landmark technique well, and most of the time there is only analgesic that is sufficient for cleft lip surgeries. Whereas cleft palate surgery, it is very difficult anatomy to block all these three nerves, greater palatine, lesser palatine, and the nasopalatine, nasociliary nerves. So the ciprozygomatic approach is used, but in clinical practice, even supported by literature, only about 50 to 60% of the patient, they will be happy, and it requires the supplementation with some other forms of like the low weak opiates like tramadol or NSA, depending on their institution protocol, it has to be supplemented.
Right. I mean, I don't think any of the methods that we use for analgesia is a solo method. I mean, it's always better in these babies to have a multimodal analgesia. And I would definitely say IV paracetamol and, you know, the blocks together can be an excellent combination. And Anand, there's one more question about you have used high flow, but how did it help in laryngospasm? Is the question that somebody has put forward for you. You used high flow oxygen in this child with severe retraction of the chest. How did that help you when the child was having a laryngospasm?
High flow nasal oxygenation was used just to rapidly insufflate oxygen. The minute the laryngospasm was identified, it was broken with the injection propofol, 1 milligram per kg propofol was instituted. Soon already the nasal oxygenation was used. And this was a particular case of cleft palate. So that when we got to know that it is a difficult airway, almost it took about 12 to 13 minutes to secure an airway with high flow nasal oxygen. So as a rescue method, as oxygenation, it was used by breaking up laryngospasm was with the propofol.
Right. Pushti, could you quickly tell us, last week you had this experience of laryngospasm. What did you do? How did you recognize? Can you share it with the PGs? Uh-oh, can't hear you, can't hear you, can't hear. Not audible. Yes? Not audible, not audible, not audible. Okay, no. No, something went wrong with the audio. Something went wrong. Okay, before Pushti can, no. Now, before Pushti can answer that question, let me tell you that there's this pediatric perioperative cardiac arrest report, which has a very important finding. It says that respiratory complication is one of the main causes of perioperative circulatory arrest. So now who is at very high risk? They say that the most vulnerable population is those little children who are undergoing head and neck surgeries that involves the airway, specifically surgery for correction of cleft lip and palate. So this is a very high risk population for us. And it has been documented that it's the respiratory problem that leads to the cardiac arrest. And Pushti, are you back? Can you answer that question now?
Am I audible now, ma'am?
Yes, better.
Okay, so first of all, the kid that we had on table was already suffering from upper respiratory tract infection, like in the healing phases. Second, after just as we started induction with sevoflurane, patient had a classical inspiratory stridor with very minimal bag movements. So we identified the laryngospasm pretty quickly, deepened with increasing the sevoflurane to 8%, gave bolus dose of propofol, I think around 1 mg per kg body weight, and then followed by succinylcholine as well as atropine we gave. During this process, I think the patient desaturated only till about 88% of SpO2 and was rapidly recovered. The bag mask ventilation was, I think, within around 40 to 50 seconds achieved that. We could manage with adequate bag mask ventilation, and we moved ahead with intubating the patient.
Right, right. So, yes, Anil, you all are still not very audible. Yes.
Just to repeat what I was speaking on my lecture, contrary to the previous thoughts where inhalational anesthesia or inhalational induction was thought to be the safest way in handling a difficult airway, particularly in this group of children, it does not hold good because of high risk of laryngospasm as experienced by Pushti and us and some of our colleagues also. So you need to be extremely careful. Though you're trying to maintain with the patient on spontaneous respiration, particularly during induction, these children, because of subclinical inflammation or hyperreactive airway already existing in that particular age, you need to be extremely careful and should be anticipating and should prepare for treating laryngospasm.
Point noted. But again, it is not only inhalational agent, Anil, that we use. We give a dose of propofol along with that. We give paracetamol. And
no, only during induction, madam. Just to take a caution during induction, because many times we.
Right. And Ramkumar sir, we would like your inputs as to why in Mission Smile we are not giving any muscle relaxants. I think you would be the best person to take that question.
Okay, Nalini. Well, see, most of us are comfortable in our regular workplace, right? And when we are out of our, normal workplace, we are working with people possibly for the first time. And I think that's one of the reasons why we make sure that we are as safe as possible. So safety is what we underline on missions. And I don't necessarily say that needs to be, that kind of practice needs to be transplanted into an institutional practice. Because where I practiced in Manipal, all the cleft lip and palate surgery that we always did with muscle relaxant. Now it's being increasingly noticed that, when you look into the literature, most of us use muscle relaxant like an anesthetic. When the patient moves, we give a muscle relaxant, and we tend to overdose our patients, right? So I think the emphasis should be more on adequate anesthesia, and again, safety factor comes in. So if you overdose our patients with muscle relaxants, there's likelihood that they may land up with a little residual neuromuscular paralysis at the end of surgery. And once again, if you have a fast turnover of patients, even in an institution, you're likely to have situations where you might shift a patient who is not yet adequately antagonized the residual neuromuscular blockade into the post-operative ward. And it is now, I think, a lot of people are rationalizing on the use of muscle relaxants, not necessarily for cleft surgery, but even other surgeries. They give it only when it's required. So I think that would be the way I would, look at this problem, be it in an institution or in a mission setup.
Right, sir. And I guess since these children use their diaphragm and the intercostal muscle, these are muscles which are very easily fatigued. And to top it up, if you have used neuromuscular blocking agents, especially now, let me restrict myself to Mission Smile. We operate on nothing less than about 20 to 25 to even more children in a day. So suppose there is some amount of residual paralysis, it becomes impossible for us to monitor post-operatively. And, because there'll be other children on the table by the time this child would have gone. Of course, he would have gone totally awake. But just in case, to our bad luck, this child has some amount of residual paralysis, probably we'll be doing more harm to the child than good. So probably that is the reason that in Mission Smile, we have decided to do away with muscle relaxants, except, yes, of course, for intubation, where we do use succinylcholine in difficult cases. Right, sir?
Right, Nalini. I did notice that Dr. Satish is on with us.
Yes.
I saw him, he was traveling. Satish, are you still connected?
Yes.
Yeah, I am very much connected. I'm sitting in a car on the side of a highway.
All right, all right. Satish, I don't know whether there are any other surgeons on the group, but I think I just want, while you are still connected with us, address a few issues that is jointly decided by the surgeon and the anesthesiologist. One of them is, I think, the question of the tongue stitch. And I do not know in your practice how, do you use it as a routine or only in special cases? Because I have my opinion, which I'll say after what you have said. The surgeon's angle first. Tongue stitch.
Sir, I work with, yeah, thank you very much, sir. Sir, I work with one surgeon, Dr. Edenwala, who had a very simple way of solving this. He said there are two types of cleft surgeons, those who put a tongue stitch and those who wished they had put a tongue stitch.
Okay, that summarizes.
So we can never go wrong with a tongue stitch.
Right. So I think that sums up the issue. So for my anesthesia colleagues, in case there is a doubt in your mind, I think I would go with Satish. Tongue stitch for every patient. I think thanks to Dr. Edenwala's teaching, I think that's a very good quote that you said. I will remember it for the future. It's not a very traumatic stitch, so to say. You can place it before you get the child out of the anesthetic, and it solves a lot of problems, airway-related issues in the post-operative period. So thank you, Satish, for saying it so succinctly. If there is a doubt, occasionally if you have a doubt between the surgeon and the anesthesiologist, what I normally do is, if I have had an airway-related problem, if there has been an airway obstruction at the time of anesthetic induction in a cleft palate. Now remember that as both the speakers, Dr. Sarika and Anil have emphasized, when the cleft palate is there, the tongue has enough space to go into that gap. The moment the surgeon has repaired that escape route is no longer there for the tongue, and the tongue becomes relatively large for the now reconstructed oral cavity. So I think we will never go wrong in placing a tongue stitch, because it can always be used to pull the relatively large tongue out, and it can be taken out the next morning. So if there is a problem at anesthetic induction with an airway obstruction, I would definitely place a tongue stitch. Otherwise, it's again between the surgeon and the anesthesiologist. But I wish we all had surgeons like Satish, who would cooperate with us and place a tongue stitch so that everybody goes home comfortable, and the post-op care is much improved with that. Thank you, Nalini. Thank you, Anil, and Sarika also. Thanks, Satish.
Thank you.
Sir. Thank you.
Satish, you're not done. You're not done. There are a lot of youngsters, postgraduates over here. So do you have a message for them as to what you expect from the team anesthesia whenever you are handling a case of cleft lip and palate?
Okay, there are a few points which I noted down. The first thing is, when we call it as a team, we need to have a team leader. The biggest challenge for the anesthesiologist is to somehow become the team leader. As a surgeon, I would be very comfortable with an anesthesiologist who acts like a boss, because the surgeon is only focused on the surgical part, and all of us are very sure that anything that can go drastically wrong in a cleft lip and palate is more likely from the airway, intubation, and those things rather than the surgery itself, especially in a cleft lip. That by itself is not a life-threatening surgery. So the preeminence has to go to the anesthesiologist, which will trip the egos of a lot of surgeons, but I think the last word has to be of the anesthesiologist. How you people are going to manage that is a challenge you have to face. But just now I heard a incident where they had laryngospasm and said the child had UTI. My personal experience is the child even vaguely mentions a cough, they don't come back and see me for minimum of 3 weeks. It's not 1 week or 2 weeks, up to 3 weeks, there's no question of doing any cleft lip palate surgery for such. And I would love an anesthetist who will on table say, no, I think there's an upper respiratory infection, we are cancelling this case. I mean, that's how we all live longer, and the children also live more safely. So that's the sort of anesthesiologist I'll be looking for.
Thank you.
I know I'm not doing this for a popularity vote, but that's the fact.
Not known to mince your words. Thank you. Yes, Satish, go on.
Yeah. The next thing is where this tongue, the tongue stitch we already covered. The nasal pack is a slightly painful part, because in palates, the anesthesiologists are always over-enthusiastic in putting a lot of this pack into the throat. Now, what that does is it pushes the tongue far anteriorly. Over that, you're putting the tongue blade of your mouth gag, So from behind the tongue is getting pushed forward, and from top it is getting pushed down behind the teeth. So the tongue gets really very compressed during the surgery of 1.5 to 2 years or 2 hours. So nobody tries to think how much of trauma the tongue itself has suffered and how much edema that will cause. I mean, we already heard sir saying that the tongue is too big for the mouth at the end of surgery. So what we are doing is going to add to that. So the tongue throat packing has to be done very lightly. I insist on doing the throat pack myself and just put one gauze piece inside. It doesn't cause any problem. I don't want a huge throat pack inside. The next point I wanted to make was that the post-surgery, I would love it if the anesthetist was to do an extubation in the lateral position. I mean, that would be very comfortable for me, because that way we are very sure the child is not going to aspirate or do anything. It would be very nice. Nalini, I'm in a very dark place, so I'm not starting my video.
That's okay. That's okay. That's okay.
So,
It's okay. Yes.
so first thing is extubation in the lateral position. That's something that I find very comfortable.
Yes.
And repeatedly tell people not to keep putting the suction tube into the mouth. Post-operatively, I would love it if the child were to be nursed into normal condition on the mother's lap, rather than on a cot or somewhere. That's the most comfortable of all the positions.
Yes.
So that is what I would suggest for all of you. So these are some of the points. And the last thing is, where pain for the palate surgery is concerned, you can ask the anesthetist. I mean, all surgeons do infiltrate the palate. If they can add a little sensor cane to the infiltration, a lot of analgesic effect is taken care of. So that solves the problem of post-operative analgesia significantly. So these are the points I wanted to make. So if
Satish, I have not forgotten those, though it was years ago. I remember Satish would infiltrate the palate and the lip and go for a cup of coffee and come back after maybe 20 minutes or 25 minutes. So that gave plenty of time for the block to act, and it cut down on the amount of anesthetics that we needed to give. So yes, Satish, is that all that you expect? Is that all that you have to convey to our people?
yeah, already conveyed more than a surgeon should convey. So I think I should stop now.
Okay, thank you. Thank you so much for being with us.
Thank you. Thank you.
Thank
It was a
you.
pleasure being listening to all the talks for the last half an hour. Thank you so much, Nandi.
Thank you. Thanks a lot.
Bye. Bye.
Nagalakshmi ma'am, are you there, ma'am? Nagalakshmi ma'am was the head of the department when Satish brought Smile Train to JSS Hospital. So, ma'am, are you there? I can't hear her, so I'm not too sure if she's there or not. But Anil, could you take another question? Are you there, Anil?
Yes, madam.
Yeah. The use of LMA for in a case of difficult airway, either a lip or a palate, does LMA have a role at all?
Madam, there are literatures, though we have not done. With LMA, there are literatures, they have done cleft lip we can do, and cleft palate also. So they have not only used in a particular in a difficult airway scenario, they have inserted and they have tried, but maybe a small length of cleft palate they have done with LMA. But theoretically speaking, the LMA, the bulk of LMA occupies the space so much, the surgeon will not get. And the second part is the airway is not completely protected when the LMA is inserted. Though there are literature supporting the use of LMA for surgery per se, but we have not used it. We have got only experience to use it as a rescue airway tube.
Right.
To maintain oxygenation and ventilation.
Right, right. As a rescue device. I think there was an article by Pankaj Kundra way back in 2019. They had studied the use of LMA. And as far as I know, I think we are very comfortable just with the endotracheal tube. And somebody has asked over here, I'll come to that subsequently. But now, should you want to use an LMA, I guess the best option would be AMBO or a GAIN, AMBO or a I, the eye gel, and the blockbuster, because you can intubate through that. So those are the four gadgets that we could have with us in case of a very difficult intubation. And probably you could even put a fiber optic through that and, thread the endotracheal tube through that. So probably this is devised for fiber optic intubation. So I think these four gadgets will be definitely worth possessing if we are doing difficult airway with the cleft lip and palate. And there was this another question for you, which said that in your institution, you're using the regular tube. So wouldn't that kink? So that was a question that was put for you.
So as already partially this question is answered by Nalini Madam, that we adequately pad in such a way that from the chest we keep a pad so that the tube almost becomes horizontal when it exits from the lip, it becomes horizontal. So with that adequate padding will prevent the acute kinking of the tube. And also it is always with the cooperation of a surgeon, which is more important. The minute it kinks sometimes, the surgeon allows us to put our finger and make it to maintain its patency. We just press it, that compression goes off. This practice started as a cost-effective methods when these government schemes started, where the 800 rupees flexometallic or the RAE tube, we were not able to use it. But now it has become a routine practice with us. So we use conventional endotracheal tube without much problem. Sometimes the kinking happens, that with communication with the surgeon, they're cooperative, so we can handle that issues. And also since the machines, the minute the airway pressure rises, we tend to know it early and we'll communicate with the surgeon. Even they can make the patency with just pressing the endotracheal.
True. And I am still a little old-fashioned when it comes to, the bag in my hand. Yes, definitely our newer machines are very intelligent and they'll tell you everything about every patient that's going wrong. But then I am very comfortable with the bag in my hand, and the moment there is some amount of compression, I know it immediately with the feel of my hand. So I trust that more than, anything else. And call me old-fashioned, but then I guess it's good. And even that old-fashioned step over the, over the chest to give you an idea of how the, the breath sounds are, how's the heart. And it may be old-fashioned, but I still feel it's a very healthy practice to carry on even today. And I don't think we can go wrong with that. Yes, we have the good monitors now. But then no harm putting that little input for the PGs today, because these are the PGs who are listening to our lecture on cleft lip and palate today. But then they are the anesthesiologists of tomorrow who are going to be anesthetizing patients for fetal surgery for repair of cleft lips and palates. So you see, because fetal surgery is definitely going to give a very good, it's a very rewarding result for the baby and for the mother. So we are dealing with the population of postgraduates who are going to be tomorrow telling us how they are giving anesthesia for fetal surgeries for cleft lip and palate, right? So, no matter how far we go, we are all based on the, strong learnings that we have learned from our teachers. Right. With that, Sarika, this thing about the sick child, right? I think you've talked enough about it. But now, is it mandatory that your child should have a 10-gram hemoglobin? What if it has 8 and it has come for a cleft lip? What if it has 7.5 and it's come for a cleft lip? Highly likely that the mother is not going to come back again. So do we go ahead and accept it, or would you want to correct the HP? What do you tell about that? No, I can't hear you. You're not audible. There's something wrong with the audio there. Not audible at all.
Ma'am, can you hear me?
Yes.
Okay. The translation for
No. Something wrong with the audio. Something very wrong with the audio.
Madam, can you hear me now?
Better. Okay. Talk loud.
Hemoglobin of 8 is acceptable for cleft lip surgeries, but for cleft palate surgery, the minimal allowable blood loss has to be calculated, and blood grouping and cross matching has to be prepared before we take up the patient for surgery. So again, during the surgery, 10% of blood loss is the allowable unit. 10% of the patient's blood volume, if it is lost, it has to be replaced. So 8 grams hemoglobin is acceptable for cleft lip surgeries.
And you would say for palate, we would ask for a better hemoglobin. For a palate, you look for a better hemoglobin.
Yes.
Okay. Okay, because not all children are going to come with the good set of hemoglobins and the counts and all that. So are you going to refuse them? Now, suppose are you going to refuse the child? Now, suppose a palate comes and it's 9 grams.
Yes, ma'am, we can accept it, provided there is adequate blood for transfusion during the intraoperative period or later.
Right. Okay. And Anil, there was one more thing that I think somebody had asked. What is the dose of intranasal dexmedetomidine? Since you mentioned, and I know you're a huge fan of dexmedetomidine, so could you elaborate a little on that, please, Anil? Anil, can you hear me?
Yeah, madam. Yes.
Yes. So that question was for you about dexmedetomidine intranasal.
It is same as the loading dose of dexmedetomidine. It is 1 to 2 microgram per kg of nasal dexmedetomidine. It is same as that of IV dose.
And what about midazolam, intranasal midazolam?
They 0.01 milligram per kg body weight.
It is muted. Nani,
Yes.
I am
Oh,
here.
yes. Naglakshmi ma'am, welcome. Welcome,
Yes.
ma'am. Welcome. Welcome. Ma'am has been a very, very prominent figure in anesthetic spheres, and she's been the head of the department in several colleges. So, ma'am, very nice to have you here. Could we please hear from you about your experiences with the program that you started? You started Smile Train and GSS. So, could we have your inputs, please?
Can you hear me?
Yes, you're very loud and clear. Very loud and clear.
Okay, thank you very much. So when I was in JSS, I was associated with the Smile Train program. And we did about more than 500 cases, I think. Satish has forgotten or remembering, I don't know. Anyway, he used to wait till I come. He wanted an anesthetist who is reliable or something like that. He said no. Hope
Yes.
Reliable after doing more than 500 cases, Satish. And he used to wait till I come. That's another one. And then the anesthetic procedures, what Anil has spoken about, is quite different from what we were doing, because the propofol and sevoflurane were not available so freely as on today. So we used to do most of the cases, especially the palates are under muscle relaxants only. And then I don't know what is the incidence of hypothermia in these children. He was repeatedly telling about that. And we usually used muscle relaxants along with 0.5% halothane, intubated all the patients with succinylcholine or cleft lip children less than 3 months with halothane. So most of the time, as it is exaggerated, I have not come across as much as laryngeal spasm and laryngeal edema in these cases. And one more incident I would like to tell. We have done a child with how important it is to, while removing the pack itself, not packing and recording that it has been removed. While removing the tube pack itself, I was just entering the OT as supervising the case. When I just entered, the baby cleft lip case was, the lips were blue. The anesthetist has removed the pack and sucking the baby. But as soon as I entered, I told the tube was slipped because the child was not yet reversed, I think. Then I immediately re-intubated the patient and ventilated and reversed. There was no untoward effect after that. But anyway, the child was very much walked home. And then Satish was telling, I don't know what complications he has experienced, but one more thing I would like to tell is, when the child is draped so much, if you have another hand with you, it is better to keep a precordial state auscultated along with your monitors.
Monitors. True, true. Yes, ma'am. Thank you, ma'am, for those inputs, because I have learned laryngoscopy by being hit on my knuckles by you, by my scope, because I was your postgraduate. And even to this day, I think I'm
minute.
quite an okay anesthetist. Yes, ma'am, please continue.
One more thing is the exaggeration about the laryngeal spasm and laryngeal edema. In these patients, we never encountered. And also, repeated attempt to intubate and putting a tube larger than what is required, and the prolonged surgical procedures. And these are some of the factors which precipitate the laryngeal spasm and laryngeal edema. Luckily, in my cases, it was very, very rare. And one more thing I would like to know from Anil, what is the dose of ketamine you were using? Because I never like to use ketamine in these patients.
Anil, that's a question for you from madam.
Yeah, madam. Madam, if we're using for sedating the patient before wheeling onto the operating table, we use maximum is a 0.5 milligram, somewhere between 0.2 to 0.5 milligram per kg body weight, titrating to the effect of sedation, just to make the child calm. Then we will take the patient onto the table. Then we will hold.
When midazolam, so many other things are available.
Madam, but because many a times what happens, midazolam does not completely calm down the patient, and child will be crying. And the crying child increases these chances of perioperative airway complications, because maybe because of secretions or the stress, anxiety, whatever it is. It is not as quickly acting as ketamine as per the sedation is concerned. So this is a practice we are practicing now in our JSS Institute.
Because it is withdrawn from the practice for using for the total procedure itself. That's why I just wanted to know.
No, procedure we are not using, madam, just to sedate. That will help in reducing the intraoperative analgesia. That was my point. When it is used, it is not a must. When it is used,
there was an incidence of ketamine morbidity in some other institute when they have used in these cases. So they were totally within that.
Anil, there is a question about IV or oral ketamine. Somebody has put a question to you.
Intravenous ketamine. I was talking about intravenous ketamine.
Right.
I didn't add the chances to use propofol and sevoflurane as much as you. Sevoflurane, some 1 or 2 cases I used, but not that much. And hope Satish remembers that his patients are all walked out safely without adding our anesthesia group.
Yeah, ma'am. Thank you, ma'am. Satish is already on the highway. I think he's driven off, so he's not connected with us anymore.
He is talking so many other things. He could do all those things without our help. He was waiting for me till I arrived to put the case on the table.
Yes, ma'am. Thank you. Thank you, ma'am. Thank you so much. Thank you so much for your inputs, ma'am.
He talked to Nalini. You please convey him to the
yes, ma'am. Yes, ma'am. Sure, sure.
What he has not told.
Yes, ma'am.
In JSS, and how you could walk out without 500 cases, more than 500 cases safely.
Yes, ma'am. Sure. Thank you, ma'am. Anil, now one more thing. Now, if there is a general feeling with the youngsters that the child is very agitated and he's crying outside. Okay. So what are the different ways with which you can bring the child inside and induce him under anesthesia?
What we are doing here, what we practice here, till maybe 5 meters from the operating theater door, the child will be accompanied by mother or the father. Yes. Where with the child sitting on a mother's lap, we give a syringe, needleless syringe to the child, and we will make the child to give his own dosage. So we'll be marked the dilute strength. So they will be very happy to give that. And this is what we are doing, and we're very comfortable with that. So before the child cries, we'll make the child sedated on mother's lap or the father, whoever is child close to, or grandmother's lap.
Right, right. Ramkumar sir, sir, if you're there, you will agree that we have a beautiful protocol during Mission Smile. We are generally two of us who always are there during induction of anesthesia. One person, we do not have the luxury of having the intravenous line put by somebody in the ward. So normally the child is brought in. Yes, he is a little sedated because we would have probably, he would be a little hypoglycemic or whatever. But before he knows it, the mask is on his face, and we would have put him on 5 to 8% of sevoflurane, and the anesthetist who's at the head end will bother only about the airway. And there will be another anesthesiologist by the side who will instantly put in the IV line. And that is one of the methods that we always use. And the moment the IV line is put, we give a small dose of propofol, the dexamethasone, the fentanyl, and the child is taken deep and intubated without muscle relaxant. If the airway is very difficult, then yes, a small dose of succinylcholine goes in. And the splinting is very important. The splinting of the arm is very important. One person immediately will splint the arm once the IV line is in position. And under no circumstances, no matter what the child does, the IV line does not go till as long as we want to remove it. So it is that good. The fixation is that good. And if I have a couple of minutes, I'd like to share a few instances which we had during Mission Smile. One of them was recently near Chennai, Melmarathur mission, wherein what happened was it was a child of about 2 months, and it was a case of retronathia, a difficult intubation, of course. So what we did was we could just about put in the regular tube. We did not put in a we did not put in a raised tube for this. We put in a regular tube, and we were just praying to God that when the mouth gag is put, it does not compress. And sometimes it so happens that, probably if, even Providence wants to check how good we are. And sure enough, the moment the mouth gag was put, there was absolute stoppage of any kind of air into or out of the tube. So you see, 3-4 times we tried maneuvering it, but it did not help. So what do? The surgeon was even ready to abandon the procedure. But then from somewhere we had our OT technician, and what he did was he says, "Ma'am, is there something that you need?" Then we said, "Do you have the stents that the urologist put?" So you see, they had a good collection of stent. He ran and he brought one. So we disconnected the connector and we put in that stent and we removed that tube and threaded a flexometallic tube. Number 3.5 flexometallic tube went in. And after that, it was a fantastic surgery that was performed. And that was excellent. I mean, so you see, these are all things that happen on the spur of the moment when we are handling, a population of about 25 cases in one day minimum. And these are things, and why I love Mission Smile, and I thank Dr. Ramkumar for having introduced me into Mission Smile, is that I love to learn and I'm still learning. And I'm so excited when I do something new every time. So thank you, sir. I'll use this platform for thanking you. If we are going overboard on the time, Dr. Meenakshi Sundaram, could you please let us know if we have to stop?
Yeah,
Yes,
madam.
Yeah.
I'm listening, but as it is, the discussion was nice and it is going on mainly the deliberations of Dr. Ramkumar and mainly the person, Dr. Satish. He is the first surgeon attending this program and he was worried about drifting the surgeon's image. Acknowledging someone's power is not drifting the image, it will add to the image of him only. But so nice, initially he was reluctant to show his handsome face. And at last he has showed his face. So thank you. And if there are no more questions, it is up to you. If there are no more questions, we can wind up. We can take 5 more minutes.
Satish is always like that.
Ramkumar sir, could you have the last word, please?
That is not the way to present himself.
Satish has a great sense of humor, ma'am. So it's okay. We forgive him for that.
Not about sense of humor or any such things. When his cases go out properly and safely, you should not make comments on anesthesiology.
Ma'am, the fight between surgeons and anesthesiologists is universal, and it adds a lot of charm. It adds a lot of charm to the OT. And Ramkumar sir, you were telling us something just now.
What sir told is correct. What sir told is correct. You should have given me timing in front of Satish. And you asked me to talk after he has left.
Ma'am, we didn't know he was going to leave. Yes, sir.
Sir, Dr. Ramkumar sir, Dr. Ramkumar sir, please, your input is much awaited by the chairperson, please.
Okay, I just want to make one point clear because there are a lot of postgraduates on this group. So we were talking about this, the cutoff of 10 grams per deciliter of hemoglobin. I think that's the answer you need to give in the examinations, right? So what we do practically later, again, depends on the discussion between surgeon and anesthesiologist. We know that cleft lip and palate are associated with nutritional issues. You have a good nutrition and a dietitian with you, we can then advise, or a pediatrician, we can build up the nutrition of the child later. But if you don't have that facility, you may have to drop the hemoglobin level to 9 or even 8 at times, provided that cleft is not, the lip is not a very big cleft. But palate, I think not below 9 would be, I think, the answer, practically speaking. But let us, for exam purpose, keep that as 10 grams per deciliter. It'll be safer to defend that. And if your examiner still probes you further and says, can you drop it any further? Then you, under this proviso, you can say that because the nutritional problems are there, I might allow it to go down by 1 gram % in consultation with the surgeon. Of course, backup blood is always available. One thing, a practical issue also is that most of these children, it's better to, in all children, I would use air bubble precautions because we do not know which child, has got a congenital cardiac defect as well. May not be a very obvious defect. So let us treat all these children as having an associated, congenital cardiac problem. And air bubble precautions need to be taken for all these patients. One last thing was, again, I wish Dr. Satish was there. Surgeons are from a point where they were going for an anatomical closure of the palate. Now they're going for a more functional closure of the palate where the speech is being addressed. And they tend to, elongate the soft palate in the process. So with an elongated soft palate, the chances of airway obstruction are much higher. It's always better to place a silicone nasopharyngeal airway before you come out of the anesthetic. And it is best that the surgeon places it because he or she knows the kind of repair that they have done. Better we do not go into that area at all. I just want to add these 3 points, and thank you very much for involving me in the discussion. It was a very good seminar, and I think we all learned from it. Thank you. Thank you, Meenakshi and Nalini, and all the speakers.
Thank you, sir. Thank you.
Thank you.
Thank you very much.
Yes, Dr. Meenakshi could, yeah, because you told
Madam,
me
so nice.
that you told me
Yeah,
very
so nice of you.
You were very
Madam,
strict with the timing. You threatened me that, I can't go beyond that certain time. So I'm very scared of that. So I think I'll abide by what you have told.
It is exactly 18, madam.
Yes.
Madam, everybody, whether you are mission smile or smile train, everybody smiled and it was a good discussion. Thank you very much. I hand over the session to Dr. Suresh Kumar, our president.
Oh, thank you. Thank you, ALM sir. A very devoted and dedicated session, webinar with useful inputs from all the 3 speakers. Excellent navigation and conduction by our chairperson with her unique voice and style, Dr. Nalini Madam. Thank you. We are very privileged and blessed by this webinar, and a wonderful and useful inputs from our Professor Dr. Ram Kumar sir, contributing his vast experiences to this webinar. And I thank Dr. Nagalakshmi Madam and Dr. Satish, who, even though his video is dark, he throws so much light on this webinar. And thank you on all. I invite our treasurer, Dr. David, to propose the official vote of thanks. Over to Dr. David. David, please.
Yes, sir. Good evening to all. On behalf of ISA Pudukkottai, first of all, I would like to thank our academic chairman, Dr. ALM sir, for successfully conducting the 30th webinar. Thank you very much, sir. I would like to thank today's chairperson, Dr. Nalini ma'am, former professor and head of the JSS Medical College, Mysuru, for sharing her wonderful experiences. Thank you very much, ma'am. And also thank today's speakers, Dr. Anil Kumar sir and Dr. Sharika Shetty ma'am and Dr. Pushti Alpesh Kumar for informative and practical oriented excellent academic session. And also special thanks to Dr. Ram Kumar sir and Dr. Satish sir and Dr. Nagalakshmi ma'am for sharing their wonderful experiences. Thank you very much, ma'am. Also thank other faculties and postgraduates and Acura A1 Logics for technical support. Thank you all.
Thank you so much. Thank you.
Thank you. And good night.
Good night. Good night. Thank you so
Good
much.
night. Good night.
Thank you, sir, for being with us.
Thank you, Nalini. Thank you very much.
Thank you, sir. Thank you. Thank you, Nagalakshmi ma'am. Dr. Meenakshi?
Yes, you can wind up, madam. Shilpa can close the session.
Okay. Thank you so much. Thank you so much to the entire team of Pudukkottai for having all of us. And we thoroughly enjoyed being with you all today. Thank you and good night.
Welcome, madam. Welcome.
Thank you.